Good afternoon, sir. Good afternoon, everyone. Am I audible?
Yes, yes, madam.
Yes.
Yes. So first of all, thank you so much for accepting the invitation. So I introduce all of you. So we are having today Dr. Kanwar Singh sir, who is working as a professor in the Department of Pediatrics in JLN Medical College, Ajmer. And sir is having the experience. Ji sir, most welcome sir, and thank you so much sir. And we are having another external, Dr. Unnati Aseri, who is working as an associate professor in NHL Medical College, Ahmedabad. Thank you, Unnati, for accepting the invitation.
Thank you.
And
Good afternoon, all.
we are having the Dr. Mukund Waja, who is working as an assistant professor in Sumandeep Medical College. And he had already worked in this college, so we are having the deep touch with him. Thank you,
Thank you,
Mukund, for
madam.
accepting the invitation.
Thank you, madam.
So we are also having the other internal examiners here, and they will join shortly. And uh, by that time, we can start the presentation, case presentation of our R3. So, Vinisha,
Uh, a 9-year-old female named Rahima Bai Khidar Node, born by consanguineous marriage, Muslim by religion, residing at Jagatpur, Dudhai, Kash, admitted in our hospital with the chief complaint of abnormal body movements for the last 8 months, which have increased in intensity since the last 5 days. This is a video of the movements with which the patient presented to us. On elaborating origin, duration, progression, the patient was relatively asymptomatic 8 months before. Then she developed complaint of abnormal body movements involving all 4 limbs, involving the distal parts of extremities, and also involving the face and trunk. These movements have decreased after medications, but non-compliance to these medications was noted, and these movements have increased since the last 5 days. Patient is unable to hold things and eat and drink properly due to these movements. All these movements are non-rhythmic, irregular, fast, abrupt, rapid, jerky, and they are also present at rest, but they disappear with sleep. There is no complaint of
Vinisha,
or
can you tell me the other abnormal movements? Other
yes,
abnormal
ma'am.
movements. And describe this movement. It is fit into the which type?
This movement is more likely to be coriform movements, which is occurring due to the lesion in the basal ganglia. Then there are other type of movements like balismus, hemibalismus, and athetosis.
Okay, what is the difference between chorea, athetosis, balismus?
Chorea is dancing, like these are like non-purposeful or semi-purposeful movements, whereas athetosis will be also athetosis will be because of lesion.
No, actually, according to the frequency, amplitude, site, we have to describe all the abnormal movements. So, in the chorea, what is the all these points? What part of the body mostly involved? What is the amplitude? What is
Basal
no
ganglia
part of
is
the body? Okay, damage will be in the basal ganglia. Okay, I'm not asking the pathology, but you have to differentiate all the body, all the abnormal movements according to the these points.
distal
Okay.
part of extremities are most likely to be involved, ma'am.
Okay. Okay. Then mostly distal part of the extremities, but proximal can also be involved.
Can also
Okay,
be
fine.
involved.
And what about rhythmicity?
Sorry, ma'am.
These other points you have to describe in the athetosis. Are they rhythmic movement or non-rhythmic?
They are rhythmic and
So,
they are.
then what is the amplitude and force of the movements in the athetosis and chorea? How you differentiate both the movements, both the abnormal movements? Because there is a very slight difference between these abnormal movements. Chorea is basically irregular, non-rhythmic and fast compared to the athetosis.
Will you please show me again that slide about involuntary movement?
Yes, ma'am.
This fifth number slide.
Continue.
Fifth number slide.
Fifth
Yes.
number slide again show. Lenisha,
Yes, ma'am.
yeah, show your fifth number slide again.
Yes, ma'am.
So you have written there is an abnormal body movement. Is there any day and nighttime variation? Is there any precipitating factors that you have not mentioned?
Ma'am, generally these movements are increased on excitement or walking, but on rest also they are present. But when the child sleeps, then these movements disappear.
So it is a gradually increased.
Yes, ma'am. Actually, 8 months before the patient presented with these complaints, and then
Hmm.
now, then she had taken medications, and then the movement had decreased in intensity and frequency. But now, because of non-compliance to medications, now since 5 days, she has presented with increased in these.
So it is a long term, almost 8 month duration of involuntary movement. Is there any other differential diagnosis than these things? Korea?
Um, Ma'am, we can suspect uh, hyperthyroidism due to that also it can happen. Huntington's chorea we can suspect.
Okay. Then
SLE,
SLE.
Wilson's disease.
Okay. Next.
There was no any complaint of fever, no complaint of joint pain, no complaint of breathlessness, skin rash, or any nodular swelling. Past history. Patient is known case of some cardiac
Lenisha,
condition that.
go back to the previous slide.
Yes, ma'am.
Why did you ask all these points? Can you explain?
Ma'am, because it is more likely to be a rheumatic cause, we can suspect because the history is a long 8 months history, and there can be a recurrence of rheumatic fever.
Okay, so what are the criteria, clinical criteria to diagnose the rheumatic fever?
There are 5 criteria, ma'am. Arthritis, carditis,
What is the name
erythema,
of this criteria? What is the name of this
modified
criteria?
modified Jones criteria. There are 5 criteria, namely there are major criteria and minor criteria. In major criteria, there are 5 criteria: arthritis, carditis, erythema marginatum, and subcutaneous nodules and chorea. And in minor criteria, we have arthralgia, fever, and increased CRP and ESR, and prolonged PR intervals on ECG. Uh, when
So any update on this criteria in 2015? Any change in this criteria according to the socio-economic status of the patient?
Yes, ma'am. There is a differentiation into low and high socio-economic status. In low socio-economic status, matlab, in when there is when there is less than two incidence of 2 in 1 lakh population ARF, or in RHD cases in 1 in 1,000, less than 1 in 1,000, then we will say they are low risk. And high risk is when there is more than 2 and more than 1 for this population. And according
Age group.
in rheumatic fever there is school age group, and in rheumatic heart disease in any age group less than 1 per 1,000, any age group. Yes.
Less than 1,000 or 1 lakh.
Less than 1 in 1,000 of rheumatic heart disease, and less than 2 in 1 lakh of school age population rheumatic fever. Uh,
Can you
and
describe revised criteria?
Yes, sir. In minor criteria, there is the change that in low, so there is monoarthralgia and polyarthralgia. Like if monoarthralgia is present in high risk, then also we can label as a criteria, and in low risk, polyarthralgia. present. Then fever also, fever difference is there, fever more than 38 degree and more than 38.5. And in ESR elevation 60 and 30, in more than 60 and more than 30 in high and low. And
So any
And
difference
also-
in the major criteria? Okay,
And
you
then there
said
is
in
even-
the,
yes,
What
any
about the
difference in the
carditis?
major criteria? Okay.
the subclinical carditis word has been added, where we can say that
Yes.
rheumatic heart disease is present even if there is finding on echo, even if there is no uh, subclinical carditis, the term is
Carditis.
added. And also there is evidence of streptococcal infection by throat swab or by rapid antigen test or by ASO titer more than 250 units or a rising titer. These are the entry criterion which should be present for diagnostic IHD. And also there is a criterion that is this, in this patient we are seeing chorea, which is an exception to the Jones criteria. If only chorea is present, then also we can label it as rheumatic.
Can you describe what type of joint pain will be present in the rheumatic fever?
There is a migratory type of polyarthritic pain present, ma'am. Other and large joints are involved, like ankle and knee. And it is, ma'am, it is painful, but it is not associated with any deformities.
Okay, which joints will not be involved in the rheumatic fever? Means if they are present, we exclude the rheumatic fever. What are those joints which are not involved in rheumatic fever?
Distal joints, ma'am, PIP, DIP.
No, rarely can be present. Which distal joint is specified? Basically, sacroiliac joint, PM joint, okay, scapulohumeral joint, they are not involved. And other can be involved, rarely also, okay. And in large major joint, other than knee and ankle, which other joints can be involved?
Elbow.
Elbow,
Hmm.
wrist,
Hmm.
okay. What type of ratios you are suspecting in the rheumatic fever? You said no complaint of skin rashes.
Yes, ma'am. Erythema marginatum can be present. It is a serpiginous type of skin rash, which is showing blanching in the center, and in extremities there is redness. And it is a transient rash. It can present and then disappear.
What is the site of rest?
Sorry, sir.
Can you describe the site of rest?
It is mostly present in the trunk region and proximal
Okay.
extremities and trunk.
And about the nodular swelling,
Yes, these are called subcutaneous nodules, which are present on the extensor surfaces like elbows and shins of shin of bone and occiput and back, and they are subcutaneous nodules. Sorry, ma'am.
nodular swelling can be
Yes, ma'am.
present
Form-
as an isolated finding, as a single major criteria. Is it possible? Subcutaneous nodule can be present as an isolated major criteria, or it is always associated with.
If subcutaneous nodules are present, then it is more likely that patient has already had cardiac involvement.
Almost
Subcutaneous
always with
nodules-
carditis.
Yes, ma'am.
Okay, always associated with the carditis, not present as a single major criteria. Okay. Okay, proceed.
Past history. Patient is known case of some cardiac condition diagnosed 8 months back. Past history of hospitalization for IM injection every 21 days since April 2024 for 5 months, after which non-compliance was noted. Past history of hospitalization for abnormal movements at private hospital 8 months back, following which patient was referred to GK General Hospital. Patient is on following medication since the last 8 months, that is tablet valproate 1 tab BD, tablet tetrabenazine 1 tab BD. Family history. Yes, ma'am.
Now continue mention.
Yes, ma'am. Family history. Patient
Just,
belongs
just
to
a minute,
nuclear.
just a minute. I want to ask something. This patient has a presentation of chorea, and the previously, if the patient has a complaint of that is choreatic movement and fever with skin rashes with somehow involvement of joint pain. So rather than this almost rheumatic fever, is there another differential diagnosis you are just suspecting? If there is no chorea, because it takes a time to develop chorea, but if the patient has a fever with rash, with arthritis or arthralgia, with skin rashes, is there, because it is a 9-year-old female child, is there any other differential diagnosis? What else will you ask? The duration of the joint pain, rashes. Got it or not?
Ma'am, there
Hello?
is no chorea, only fever and rash is present.
Yes. Because chorea is time to take a, it is time to develop a chorea. Barabar? But if the patient has only fever with rash, arthritis, so is there any other 9-year-old girl? Is there any other chances, differential diagnosis? What about the SLE?
Yes,
Is there
yes,
any
ma'am.
chance?
Yes, ma'am. SLE can present.
So which are the other differentiating point?
Cardiac involvement is present in more in rheumatic disease, in
Okay,
acute rheumatic.
yes. So in this
Pericarditis can be there
subclinical,
in SLE. Vidisha, pericarditis can be there in SLE or not?
No, ma'am.
Arthritis, rashes, everything, even SLE neurological involvement can also be there.
yes.
So how will you rule out that this patient is not suffering from SLE, only rheumatic fever? What are the points which suggest, which favor that this patient is definitely having the rheumatic fever, not the SLE?
I mean, SLE, there is a typical type of butterfly rash, and there is malar prominence of the rash, which is not seen in acute rheumatic.
Okay.
And
What about the joint pain?
in joint pain, ma'am, in rheumatic heart disease, there is painful and migratory polyarthritis, whereas in SLE, it is not that much painful. And SLE, ma'am, other features are present, like kidney involvement can occur, and which is not more present in rheumatic.
What is the characteristic of joint pain in SLE and in which differentiate from the rheumatic fever? SLE का joint pain कैसा होता है? It is an autoimmune disorder. So what type of joint pain patient will have? Patient will have
Small joints are more.
Okay. Other than this,
You can continue.
okay. Continue the next slide.
Yes, ma'am. Family history. Patient belongs to nuclear family with 10 family members residing in Kacha house, and age of mother is 35 years, age of father is 38 years. No history of TB, hypertension, diabetes, obesity, convulsion, or any heart disease in any other family member. This is the pedigree chart. There is a consanguineous marriage between mother and father, third degree consanguineous marriage, and there are 10 siblings. Socioeconomic status, there is a nuclear family with father, mother, and 10 children. And according to socioeconomic status, it is belonging to upper lower class. And antenatal history. The child was spontaneously conceived at 25 years of age, booked and immunized, mother took iron and folic acid supplementation, no history of fever with rash, no history of drug intake or radiation exposure, no history of anemia, GDM, PIH, thyroid, or any maternal diseases. Natal history, term, normal vaginal delivery, delivered at CHC Dudhai, with birth weight 2.8 kgs and cried immediately at birth. Postnatal history, no history of NICU admission, immediate and later postnatal events were uneventful. Developmental history, development is appropriate for age, and the child is studying in 4th standard with good scholastic performance. DQ is 90 and IQ is 90 to 109. And immunization history, taken vaccine up to 6 months of age, and thereafter no vaccine is taken. BCG scar is present.
How to calculate the IQ? 90 to 109 for this child.
And according to Binet Kamet scale, we did.
You have mentioned that baby is having the normal IQ and EQ. Baby is having affected speech or not? Child is having the affected speech or not? This child is having speech normal.
Yes, ma'am.
Okay. Language, speech, both are not affected. Okay, fine. Move.
Now patient has developed chorea since last 8 months. Hello.
Yes, ma'am.
Now the patient has developed the choreatic movement since last 8 months. Is there any regressions or developing some behavioral issue or somehow difficulty in writing that you have to mention also?
Ma'am, she was able to write. I made her write. She was
There's
able
no
to
any
write.
in the handwritings.
No, ma'am. And scholastic performance was also good.
Also, there's no any other behavioral issue you found. There's no any regression. Nothing is like that.
No.
Nothing, na?
Felicia, she is going to the school right now also.
Yes, ma'am. Yes, ma'am. She's in fourth
After the
standard.
onset of disease, is still going in
Decreased
last
in,
8
ma'am,
months.
because of the movements, ma'am. They are saying that it has decreased. She goes to school less, and but when she took medications, then again she was able to.
So which are the clinical maneuvers to elicit the chorea?
Ma'am, there are different signs we can do.
Yes.
There is milkmaid sign, hyperpronation sign, darting
Okay.
tongue, then there is piano-like movements of hands, and there is dinner fork deformity signs.
Okay. Okay. Continue. Continue.
Yes, ma'am. Diet history, patient takes 695 kilocalories and 28.5 grams protein, and there is a deficit of 985 kilocalories and 0.5 grams protein. Anthropometry, weight is 18.2 kgs, which is less than the third percentile. Height is 123 centimeter, which is between 10th and 25th percentile. Head circumference is 48 centimeter, which is less than the third percentile. And BMI for age is 10.9, which is less than the third percentile. Segment is the lower segment ratio is 0.9. Arm span is 126 centimeter. General examination. The patient is in lying down position.
Felicia, what is the importance of taking the arm span in this child? What is the importance? Why we are taking any syndrome in which arm span will be affected with the cardiac lesion?
There
Is
is
there any syndrome?
Marfan syndrome where arm span is more than the height, and Klinefelter syndrome, and even in homocystinuria we can see arm span more than height.
So whenever a patient is having the cardiac problem, we are taking the arm span to rule out the Marfan syndrome. Okay. Move to the next slide.
Yes, ma'am. General examination. Child is in lying down position, normal posture, fully conscious, oriented to time, place, and person, having normal hydration, underweight, and poor nourishment and growth. Vitals, temperature is 99 degree Fahrenheit, taken from right axillary region with a thermometer. Pulse rate is 100 per minute, regular, grade 3 intensity, normal volume and tension, normal character of arterial pulse, normal vessel wall thickness, no radial or radiofemoral delay, no apex pulse deficit. It was taken in right radial artery in supine position. All peripheral pulses are well fed. Respiratory rate is 18 per minute with thoracoabdominal type of breathing, normal depth and regular rhythm. SpO2 is 99% on room air. No sign of respiratory distress. BP taken in all four limbs is between 5th to 58th percentile. Neck JVP measured is 6.6 centimeter. Head to toe examination.
Go to the next slide. Previously.
Yes.
BP in all four limbs Next,
Yes, ma'am.
BP in all four limb almost similar, 90 to 90, 98. What is the difference between upper limb and lower limb BP?
Normally, ma'am, it should be less than 20 mm Hg.
Okay. So what is the significance? Why we are taking the BP in all four limbs?
To rule out, ma'am, any other congenital disease like coarctation of aorta.
No, particularly in this child, why we are taking the blood pressure in lower limb also? Child is having the rheumatic heart disease, so you want to rule out what? Which valves involved in the rheumatic carditis?
Mostly mitral valve involvement is seen.
If the difference between the upper and lower limb BP is more than 20 mmHg, then what will you suspect? Which valve can be involved?
We can suspect aortic regurgitation, in which the difference is more than 20 mmHg, and in severe aortic regurgitation, difference is more than 60 mmHg.
What is the name of this sign when BP difference between upper and lower limb is more than 20?
Hill's sign.
Okay.
Head to toe examination. Head circumference is 48 centimeter, microcephaly, no frontal bruising, closed AF and PF. Face has normal symmetry. Eyes have normal eyelids, eyelashes, no pillar in lower palpebral conjunctiva, no ptosis. Ear, pinna size, shape normal, no low set ear. Nose is normal in shape. Oral cavity shows no dental caries. Tongue shows darting on protrusion of tongue and no lymphadenopathy. This is the video of the tongue.
One question. Excuse me. Name the different shapes of head.
Brachycephaly, dolichocephaly, plagiocephaly, trigonocephaly, oxycephaly.
Okay, how will you differentiate it? Or which index is used to differentiate it?
We will take the AP diameter and
Okay. So how? What is definition of brachycephaly?
there is a reduced AP diameter and there is a flat occiput.
So which suture is closed premature? Okay, go ahead. Go ahead.
Chest elliptical in shape, normal position of nipples, no dilated veins, no scar, prominent precordial pulsation. Abdomen flat, umbilicus in normal position and shape, no any dilated vein or scar over abdominal skin. Upper limb and hands, no pallor on the palmar surface of hands. Involuntary, non-repetitive jerky movements involving hands and finger are seen, which disappear on sleep and aggravate on excitement. And in lower limb and foot, no edema is seen. Involuntary, continuous jerky movements involving legs and toes are seen, which disappear on sleep and aggravate on excitement.
Finish which abnormal movement not disappear during the sleep time? All other movements disappear during the sleep time. Only one abnormal movement which persists even during the sleep. Which one? Tell me which abnormal movement even persists during the sleep. Do you know?
No, ma'am.
Okay. Ask Maitri and Path. Both are here.
Yes, ma'am.
If they know, they also reply. Which abnormal movement? Which abnormal movement even persists during the sleep? What are the various abnormal movements? Just tell the name.
Bellismus, hemibellismus, dystonic movement, coriform movement,
Myoclonus. And myoclonus can persist even during sleep. Both. It can be non-epileptic myoclonus and epileptic, which we consider as in epilepsy. Okay, so non-epileptic myoclonus can persist even during sleep. Okay, move to the next slide.
Yes.
So what is the latent period to develop choretic movement in a Wilson disease and from a rheumatic fever?
In rheumatic fever, approximately 3 to 6 months.
Okay. And for the Wilson disease, if the patient has developing chorea, what is the latent period?
It is more.
So it is in the years.
Yes, ma'am. Years. 1 to 2 years. And
Yes.
late presentation. Very late presentation.
Appears in a early infancy or in the pediatric patient. It takes at least years, 3 to 5 years to develop. Untreated develop at least years to develop choretic movement. But in the rheumatic fever, it appears in the months. Okay.
Nails show normal, no pallor, skin normal, no nodular swellings and no rashes. CNS examination. Patient is fully conscious, alert, has normal appearance and behavior, no delusion or hallucination, has normal emotional status, is oriented to time, place, and person, normal memory, normal intelligence, speech, and no any sign of meningeal irritation. Cranial nerves.
Denisha, what is the characteristic triad of syndactyl chorea? Rheumatic chorea. What is the characteristic triad? Go to the previous slide. 28 number, 28. 28. Yes. You say patient is having normal emotional status. So what is the characteristic of syndactyl chorea? What is the triad to make the diagnosis of rheumatic chorea? There are three things should be there.
There is coriform movement and there is emotional lability also. In this patient, it was not there. And there is a presence of anti-neuronal antibody, which you can see. It is diagnostic.
No, in triad, these two things, okay, chorea and emotional lability. Other than this, hypotonia. Okay, good.
Cranial nerve examination. All the cranial nerves were examined, were found to be normal, right and left. Olfactory nerve, normal sensation of smell. Optic nerve, visual acuity, visual field, color vision, fundus. Color vision were normal, fundus was not assessed. Oculomotor, eyeball is normal in shape, position, and movement bilaterally. Direct consensual right reflex present. And there is no ptosis, accommodation reflex is present. And trochlear nerve, all bilateral extraocular movement, muscle movement is normal. Trigeminal movement, sensation, motor part is normal. And all reflexes are normal. Facial, there is no any deviation to any side, normal symmetrical face, normal tongue sensations. All the cranial nerves examination was normal in this patient. Motor system, posture is normal, bulk of muscle is normal, tone bilateral.
In 12th, now you have mentioned that in 33, 35 numbers like.
Yes.
Tongue protrusion normal, no deviation. But at least you have to mention
darting tongue, but there is no.
You have to maintain the movement.
But at least you have to mention here also.
Okay, ma'am. Motor system, posture is normal, bulk of muscle is normal, and tone in bilateral upper and lower limbs is normal. Power is 5/5. Deep tendon reflexes are all normal in upper and lower limb. Superficial reflexes are also.
Tone is also normal in this patient. Patient is not having hypotonia.
No, ma'am, this patient is not having.
Okay, how to assess the tone? What are the methods to assess the tone?
We can do by flappability of the muscle. And
Okay.
then we can touch and feel by passive movement we can do, and we can feel the.
What is the difference between passive tone and active tone? Okay. Yeah. Okay, continue, Diksha.
Yes, ma'am. Gait. There is a hyperkinetic gait in this patient. As you can see.
Diksha, in this patient, all four limbs are involved.
Yes, ma'am.
So it can be possible half part of the body is affected. In Korea, only single limb can be affected. Is it possible or not? Always patient is having the involvement of all four limbs, or is it possible unilateral or hemi?
All generally full limbs. Lower limb is more involved.
So it can be unilateral also, or it can be hemicoria also. It's not necessary that whole body will be involved in all the patients. Okay. So,
This is also a video of the gait, which is after treatment.
Speed manager.
This is a video of the signs which we perform.
just click on the video. Okay, move to the next slide.
आगे पकड़ जाओ आयत ना आयत पकड़ जाओ पकड़ यार जल्दी चलना पकड़ दे आम करना आम कर वीडियो कर जाओ आम कर आम
Will you please describe the hyperpronation sign? Describe. How will
Yes, ma'am. When we ask the patient to extend both upper arms, and then there is hyperpronation of the upper hand.
Okay.
And this dinner because when we hyperpronate, she cannot maintain the limb like that.
Okay.
And there is milkmaid sign where the grip is very loose. It tends to like the grip will loosen up when normally it should.
You can continue next slide.
What is wing beating sign? What is wing beating sign and present in which condition?
Wing beating sign is present. Wilson's.
Okay.
Wilson's
How
disease
you,
is present.
how you
There
tell
is
the
a
patient?
movement. In this, there is distal tract involved, but in Wilson's wing beating tumor, proximal part will be more.
No. How you demonstrate being beating sign whenever patient is ready? What is the position of the limbs?
Um, Extended and in front, you tell the patient to place the.
No. Maitri or Parth can reply. What will be the position of limb you will keep to demonstrate the wing beating sign?
We'll ask the patient to outstretch the hand in front of the patient, and on applying pressure over the fingers, there will be tremors like the beating of wings.
No, this is the way to demonstrate the tremors, but in wing beating sign, we have to keep the patient to keep both the hands in this position. Abducted and extended shoulder and elbow should be flat. Then there will be abnormal movements visible as a wing beating. Okay. Right. Next slide.
Sensation, superficial touch normal, normal, temperature normal, deep pressure, vibration, position sense normal, cortical 2-point discrimination, tactile localization, and cerebrosis and hypophysis all normal. Cerebellar, there are no signs
How
of
to
cerebellar
point
dysfunction.
discrimination technique? Will you please elaborate? How will you do the 2-point discrimination? Hello?
We can take, yes, ma'am. We can take 2-pointed objects and the distance between them we have to this, and we can take a divider if present, then we can measure. We can put two it and that increase the distance and decrease it, and then we can see.
Okay.
There are cerebellum. There is no sign of any cerebellar dysfunction, and autonomic nervous system was normal, and shape of skull was normal. There is microcephaly. CVS examination. Inspection. Shape of chest is normal, elliptical. Symmetry of chest wall is symmetrical. No chest deformities, no precordial bulge, no engorged veins over chest wall. Trachea is central in position. Apical impulse is diffuse, which is seen in 4th, 5th, and 6th intercostal space, lateral to the mid-clavicular line. And visible pulsations are seen in aortic, pulmonary, and suprasternal areas. There is no pulsation in PSG, carotid, and back regions. GVP is 6.6 centimeter, no engorged neck veins, and hepatojugular reflex detection. Palpation, tracheal position is central. Apical beat is hyperdynamic, forceful apical beat involving 4th, 5th, and 6th left intercostal space, extending downwards and outwards. And point of maximal intensity is 5th intercostal space, lateral to the mid-clavicular line, felt in more than 1/3 of the systole. Palpable thrill, systolic thrill felt diffusely in the mitral area and the area lateral to it. Parasternal heave, grade 2 left parasternal heave is felt.
So
Percussion.
what is the apex? What do you mean by apex?
Sorry, ma'am.
What is the apex in a heart?
The left, the maximal, the point of maximal where impulse is present,
It is the
and
most
left-sided
outward end.
heart, left ventricle.
Pardon? It is the most
Left.
outward end. It is by left, obviously left, but it is the most outward and downward part of the heart. What is the thrill?
What is?
What is the thrill?
Thrill.
You are mentioning a thrill, huh? What is
We
that?
can feel there is we can feel there is pulsation of there is a murmur. Due to the murmur, there is a diffusely touching
So it is a
impulse which
palpable
is present.
murmur.
Palpable, yes.
It is a palpable murmur. So in which grading of murmur you are able to palpate the murmur, thrill?
In grade 3, we can palpate.
After
From
grade
grade 3, we can.
3, 4, 5 specifically, you just see the thrill. Okay, continue.
What is parasternal heel, Vinishi? What do you mean by parasternal heel?
Ma'am, on placing the ulnar border of the hand, or we can put this border, we can feel the the impulses coming and going, and we can feel the on the left side.
In which condition parasternal heel will be there?
In mitral regurgitation, you can see left-sided parasternal heel.
Okay. Due to which chamber will be enlarged, then you will feel the parasternal heel. Right or left, ventricle or atrium. Which heart chamber will be enlarged, then you will have the parasternal heel.
There is left atrium enlargement, and then there is backflow, and then there is right ventricle. Because then we can see left parasternal. Percussion, left heart border is percuss and dullness correspond to the apex beat. Right heart border is percuss and dullness corresponds to the right sternal border. On auscultation, mitral area S1 and S2 is normal, and there is a pansystolic high-pitched blowing murmur of grade 6, which is best heard in the mitral area in the left lateral position, with radiation to axilla and back, with a diaphragm of stethoscope. In the pulmonary area, S1 is normal, S2 is loud, P2 component is loud with normal splitting of S2, no added sounds, and the same murmur is heard. Aortic area, S1 is normal, S2 is normal, no added sound, and same murmur is heard. Tricuspid area also S1, S2 is normal, no added sound, and the same murmur.
Go to the
Clinical.
previous slide. 51, yes.
Yes, ma'am.
Always you have to mention the heart sound first, then explain the murmur. Here you have mixed according to the area. So in the mitral area, you have mentioned that S2 is normal. And in pulmonary area, you have mentioned that S2 is loud. So either loud or normal. So first you have to explain sounds, then murmur. Okay. And for the murmur, you have to tell about the in which area murmur is audible in the maximum intensity. It's okay. According to this slide, in mitral area, you are saying the S2 is normal, and in pulmonary area, you are saying the S2 is loud. So better to write the S1, S2, and other S3 or S4 if it is audible. Yeah?
Because in the
S3
grade,
is audible.
it is not a differentiation between S1 and S2 differently. It is always merged with the pansystolic murmur. You just see the gallops also in the apical region, mitral region. So you have written the S1 is normal, S2 is normal, then you have written the murmur. But you have seen the intensity is a grade 6. That means there is no differentiation between the grade S1, S2. Got it? It is
Yes.
always like a gallop. You just heard the gallops with intense pansystolic murmur leading toward along with the thrills. That is that much of intensity is there. So there is no normal S1, S2. You are not able to heard also. Got it? Okay.
Clinical diagnosis, recurrence of rheumatic fever in a known case of rheumatic heart disease.
Will you summarize because ना वो भी रह गया उसका after history तो अभी examination भी हो गया है तो will you please summarize your case if I ask summarize your case will you please tell me your positive finding and give me summary.
So, the case of a 9-year-old female patient who presented to us with chief complaint of abnormal movements of body, which was present since last 8 months, and now it has increased in intensity since last 5 days. There is likely involvement of there is likely coriform movements, and we can also see a pansystolic murmur in mitral area, which is suggestive of mitral regurgitation and rheumatic heart disease
Rheumatic heart disease.
and
Okay.
rheumatic chorea.
Okay. Okay, continue.
Clinical diagnosis, recurrence of rheumatic fever in a known case of rheumatic heart disease with rheumatic chorea in an unimmunized and underweight child. And can do differential diagnosis of Huntington's chorea, SLE, hyperthyroidism, Wilson's disease, familial chorea, and drug-induced chorea.
What are the drugs which lead to the chorea? Can you tell me a few drugs? He
Ma'am,
said drug
levodopa, tricyclic antidepressants.
No, we are using commonly. Tell me the example. Any anticonvulsant which can, any drug which we are using. Phenytoin and valproate both can cause the chorea. Okay, so there are various drugs, but these two drugs we are using in various patients with the epilepsy. Okay, fine.
Investigation, chest X-ray, CBC, hemoglobin, WBC, that 10.3, WBC 7,400, platelets normal, CRP 9.3, ESR 82, and ASO titer is negative. This is a report of the 2D echo, which was done in up before 8 months. And in this also there is MR, findings of MR are present. This is a recent echo which we got, which shows MR and MVP. Final diagnosis, recurrence of rheumatic fever in a known case of.
What are the common finding of the MR in the echo? How will you grade the severity of the MR according to the echo report? Mild MR, moderate MR, severe MR according to the echo.
There is a criteria which is present that in more than 2 views we have to see the flow of the jet, and the length of the jet should be more than 2 centimeter, and the velocity of the jet should be more than 3 meter per second. And criteria grading.
Okay. Fine.
Final diagnosis, recurrence of rheumatic fever in a known case of rheumatic heart disease, mitral regurgitation with rheumatic chorea in an unimmunized and underweight child.
So what is the organism responsible for the acute rheumatic fever?
Group A streptococcus, beta hemolytic streptococcus.
To classify the streptococcus according to microbiology, so it is the very initial part. So how can you classify the streptococci?
A, B, group
A.
A, B, C. Group A, B. Then
Yes.
in the
Then
A we have alpha, beta.
so again in the group A it is a depending
Beta
upon the
hemolytic.
hemolytic.
Beta hemolytic streptococcus.
अल्फा हेमोलिटिक हम बोलते हैं ना जैसे अल्फा हेमोलिटिक बीटा हेमोलिटिक ग्रुप ए बीटा हेमोलिटिक स्ट्रेप्टोकोकाई तो अल्फा बीटा एंड gamma. So is there any significance of these organisms?
Ma'am, the organism subtype causes molecular mimicry in rheumatic heart disease. So it is more.
It is like an autoimmune effect. So which are the presentation of that streptococcus pyogen? ये हमें पता चल गया कि बच्चों में रूमेटिक फीवर होता है, यूमेनोनेफ्राइटिस होता है, that is a non-suppurative complication. But which are the other presentation of that is suppuratives? क्या दिखने को मिलता है बच्चों में हमें?
Sore throat होगा.
Okay. Tonsilopharyngitis. What else?
Skin infection.
Pardon?
Skin infection.
Skin infection in the form of
Pyoderma.
pyoderma, impetigo. और स्किन में क्या होता है? More invasive, more severe variety that we are seeing sometimes. What about toxic shock syndrome, scarlet fever?
Any other organ which can be
Yes.
affected by the same mechanism, molecular mimicry? Kidney can be involved.
In rheumatic cases,
What are the strain of the group A beta hemolytic streptococci can causes the rheumatic fever?
M
It's
type
strain
1, 3, 5, 6, 9, and 18. M.
Okay.
So if the one-time patient has developed rheumatic fever followed by chorea followed by rheumatic heart disease, now it is a recurrence. Okay. So how will you prevent recurrence?
We have to use the antibiotic prophylaxis. The drug
Okay.
preferred is benzathine penicillin.
Hmm.
We use IM, and it is given every 21 days, so that
What is the
we can
penicillin? Just tell me the full dose.
in less than 30 kgs, it is 0.6 mu per kg, and in more than 30 kgs, it is 1.2 million units. And
Okay.
the length of prophylaxis depends on heart disease. If there is no if there
So
is
in
no
this,
carditis,
ये बच्चे में आप कितने टाइम तक दोगे? आपको ये बच्चे बोलना है मुझे फॉर द प्रिवेंशन के लिए.
up to 10 years or up to 25 years of age, whichever is longer.
Whichever is longer, 10 years. Okay. Then what else you can give?
For the movements, we can give valproate.
Valproate. Else? Any other treatment?
For first, when there is such episodes, we have to advise bed rest to the patient. Then we can give suppressive therapy. That is, we can give aspirin or we can give prednisolone.
Okay, continue.
How long you will continue the prednisolone and
आपके
aspirin?
बच्चे सेंसिटिव है पेनिसिलिन से, which drug can you use? आपका बच्चा सेंसिटिव है by benzathine penicillin. You have any other option?
Erythromycin we can.
What is the dose for this patient? डोज क्या दोगे इस बच्चे को? आपका बच्चा है जो 9 ईयर का, वेट के अकॉर्डिंग कितना दोगे आप? प्रोफाइलेक्टिक डोज या कितना दे रहे हो इसको? प्रिवेंशन के लिए क्या डोज दोगे एरिथ्रोमाइसिन का?
What 40 mg per kg.
40?
Penicillin.
It is prophylactic dose or therapeutic dose?
Diphtheria we give 40.
नहीं, इस बच्चे में क्या देना है इसको? डिप्थीरिया नहीं है इसको, तो रूमेटिक ये सेंसिटिव है पेनिसिलिन से. इट इज ए रिग्रेंस है. रिग्रेंस मींस करंटली पेशेंट हैव रूमेटिक फीवर है, प्लस इसको कोरिया हो रहा है, तो अभी क्या इसको ट्रीट करोगे पहले?
सर मतलब वी हैव टू गिव मूवमेंट्स के लिए वाल्प्रोएट देंगे और सप्रेशन के लिए प्रेडनिसोलोन.
नहीं, फॉर गैस मींस स्ट्रेप्टोकोकस के लिए क्या दोगे आप? अभी आपने बोला ना कि ये रिकरेंस हुआ उसको, रूमेटिक फीवर दोबारा हो गया, यही बोलना चाह रहे हो ना आप अपने केस में?
Yes, sir.
तो उसको ट्रीट कैसे करोगे? कि दो चीज है कि एक ट्रीटमेंट एंड प्रोफाइलेक्सिस.
पेनिसिलिन देंगे सर 1.5 लाख IU per
पेनिसिलिन आपका
kg.
सेंसिटिव है ना? सपोज करो आपका बच्चे को
Erythema.
सेंसिटिव है, मेरा क्वेश्चन ये पूछ रहा था। चलो नेक्स्ट कंटिन्यू।
Vidisha, what is primary prevention? What is secondary prevention? And what is primordial prevention? What is the difference between these three?
Primordial prevention means the risk factors only we can remove, like in this patient, low socioeconomic status is there, overcrowding, all this. And in primary prevention, we can treat the sore throat. When the sore throat had happened, that time we can give antibiotic within the first 10 days, treat the sore throat. So that is
Which antibiotic we have to give for the primary prevention? Which antibiotic? Just tell me the name of the antibiotic we can choose. You will give the primary prevention antibiotic for 10 days. Okay, fine.
Amoxicillin B. Amoxiclav.
Okay, amoxicillin. Other than this?
Can give cefixime or ceftriaxone. Azithromycin we can give.
Can we give cefixime? You said cefixime. Cefixime is effective against the Streptococcus. Can we give? Which cephalosporin is effective against this organism? There are two cephalosporin which are effective. We can give, but not the cefixime. Cefixime is not effective. So, tell me those two cephalosporin. First drug of choice is still penicillin. Okay. We have to give the oral penicillin for 10 days. If patient is sensitive, then you can choose the other antibiotic. So in this, okay, amox, other than this azithro, erythro, clavithro, okay. But in cephalosporin, which drug is effective? Sulfhydroxyl, cephalexin, okay, not cefixime. Okay, move to the next slide.
So if any school-going children or child has having a acute pharyngitis, how will you differentiating it is a viral or bacterial? First of all, because we are now telling that no need to give antibiotic, no need to give antibiotic. We have to differentiate whether it is viral pharyngitis or acute bacterial pharyngitis. So how will you differentiate?
In bacterial pharyngitis, there will be fever will be present more, and also there will be when we do investigations, the WBC counts.
Just tell me the clinical features. So how clinically you just see the patient having a bacterial pharyngitis or viral pharyngitis?
Bacterial pharyngitis patient will have sick look, more fever will be present.
High grade continuous fever. Duration, is there any rule of duration? What next will you see? If it is a viral pharyngitis or viral URTI, what else will you see?
Viral URTI will resolve on its own, but bacterial will remain for more time, and fever is persistent.
Persistent. So viral, it is a low grade, low to moderate grade fevers with runny nose, with maybe conjunctivitis. What else will you see? Okay, let's continue.
Can you differentiate? Can you confirm your diagnosis of acute bacterial pharyngitis by throat swab or any blood investigation?
We can confirm by throat swab, and we can confirm by ASO titer in this patient.
Okay.
And
So what is probability if the patient having a recurrence of rheumatic fever in a rheumatic heart disease patient? एक बच्चे को एक बार तो हो गया rheumatic heart disease, लेकिन उसको recurrence कितनी बार होगा? What is the probabilities? Incidence. So it is a 7 to 80% chance that this patient has a recurrent rheumatic fever in a known case of rheumatic heart disease. If it is less than 5-year-old, the probability or increase. But if it is more than 5 years old, the probability will decrease as the age increase. Okay. Continue.
Slide. This was my last slide.
Okay. So what about the unimmunization and the underweight? How will you manage that portion in this child? Because you are managing everything. You are giving the treatment for the chorea. You are giving the prophylaxis. You are treating these episodes also. But what about the unimmunization and the underweight child? Have you done anything?
In with underweight child, we can treat by advising her to take diet. We can advise her. She eats 2 roti, so we can tell her to add 1 roti. Then she is a non-vegetarian in diet, so we can add meat in the diet. We can add egg in the diet. We can add ghee in the dal and everything, so that we can increase the caloric content of the food.
And how will you immunize? She is a 9-year-old.
Can do MMR vaccine. We can give, and we can give hepatitis B vaccine.
MMR and
Hepatitis B.
okay. And
Then hepatitis A we can give.
SA. So you have no any plan. How will you immunize step by step? Because she's already 9-year-old.
Age of vaccination for a 9-year-old unimmunized child. Ma'am is asking.
You have to do some planning, na? कि अभी बच्चा आया है तो अभी आपको before discharge, is there any way can you give vaccine or not? If give, then which vaccine will you give first and second? Okay, continue. Next. Any question?
इसको आप काउंसलिंग कैसे करेंगे बच्चे को, क्योंकि इसको हार्ट डिजीज है, फैमिली और को कैसे काउंसलिंग करेंगे आप इसका टू प्रिवेंट द फर्दर डैमेज और रिकरेंस और एनी कॉम्प्लिकेशंस?
Hi, we can prevent the recurrence. Regular prophylaxis देने को बोलेंगे.
नहीं, घर वालों को क्या बताएंगे आप? काउंसलिंग कैसे करेंगे? आपका घर वालों को क्या कहेंगे आप? उसके जो माता पिता को आप क्या बोलेंगे?
अगर if the child, अगर उसको डिस्निया, ब्रेथलेसनेस या ऐसा कोई भी फीचर आए तो वो तुरंत केयर सीक करना है और प्रिवेंट करना है कि रिकरेंस ना हो. सो वी कैन उसको एडवाइस करेंगे कि मतलब हाइजीन मेंटेन करें, और अंडरवेट है तो वो न्यूट्रिशन इंप्रूव करें.
We have to first
ट्रीटमेंट के
assess
बारे में काउंसलिंग करेंगे. जो एसेंशियल पार्ट है कि ट्रीटमेंट पे इसको दवाइयों पे अडेरेंट रहना है.
yes.
तभी तो प्रिवेंट होगा. इसको आपका पेनिसिलिन रेगुलर लेना है, ठीक है ना? और जो आपका जो कोरिया है, जो उसको आप ट्रीट नहीं करोगे तो क्या होगा? इसमें इसकी इस बच्चे का स्कूल गोइंग वाला है, इसका स्कूल परफॉर्मेंस कम होगा. आप ट्रीट नहीं करोगे तो कोरिया को, तो क्या रहेगा? बच्चा स्कूल्स में पीछे रह जाएगा, क्लास में फेल हो जाएगा. तो ये जरूरी है कि ट्रीटमेंट उसको पूरा करना है, समय पे दिखना है और रेगुलर फॉलोअप करना है. ओके?
Yes.
Now we need to tell part to come here, and we will take the biome part on 9th and slate.
Okay. Thank you.
So there are 2 more students, so we will take the oral biome of both of them.
Good afternoon, all.
Good afternoon.
So we have to take the oral biome on IMCI of this student.
Okay.
So from internal examiner, I request Dr. Shami and all three of you should continue. Parth, can you start the presentation, please? So, Parth, as per IMCI, which are the general danger signs that you will look for in a child?
For general danger sign is there. One, history of convulsion in present illness. Child having convulsion on admission. Child vomiting everything, or child is lethargic or poor feeding or unconscious.
Then, as per IMCI, how will you classify pneumonia? As per IMCI.
As per IMCI, 3 classifications are there: no pneumonia, pneumonia, and severe or very severe pneumonia. In normal no pneumonia, only cough,
No
cold are
pneumonia.
there.
No pneumonia. Yes, sir.
Means cough
Is
and
it
cold.
like that?
No cough, cold without pneumonia.
Okay.
No
Go
any
ahead,
sign of pneumonia or severe pneumonia. In pneumonia, only fast breathing or chest indrawing are there, and very severe
Then how do
pneumonia.
you define 8-minute path? How do you define fast breathing as per IMCI? What is the cutoff age was?
Fast, less than 2 months, more than 60 per minute, 2 to 12 months, more than 50 per minute, and more than 12 months, more than 40 per minute. 40 per minute is called fast breathing as per IMCI.
It is
And
more
more
than
than
50,
5 years?
40. It is more than
More than
50,
30.
40 or 60. Yeah, 50 or more, or 40 or more, or 60 or more. What is cutoff value of respiratory rate?
More than 60, less than 2
60
months.
नहीं चलेगा? 60 पे नहीं होगा pneumonia?
60 or more than 60.
हाँ, 60 or more.
60 or more than
50 or
60,
more.
50 or more. And very severe pneumonia is any general danger sign or stridor at calm.
What about chest indrawing?
Chest indrawing, suprasternal, substernal retraction, supraclavicular retraction, and accessory muscle are used for
Which retraction is more important for diagnosis severe pneumonia? It is intercostal or subcostal?
intercostal. Sorry, subcostal pneumonia. Subcostal retraction are
Okay.
for severe pneumonia.
So what is a stridor?
Stridor is a expiratory sound caused by narrowing of respiratory tract.
Expiratory or inspiratory?
Both inspiratory or
Most
respiratory.
commonly it is.
No.
It may be expiratory, but most commonly stridor because of inspiratory.
Inspiratory. Because of? Due to? Which
Narrowing
part is
of
involved? Narrowing of?
vocal cord or larynx.
Upper airway, specifically
Upper
upper
airways.
airway obstructions.
Because of
Barabar. So what is a grunting? Then what is a grunting?
narrowing of glottis.
Yes. So what is a grunting?
Grunting is a sound which is produced in due to the any lung lower respiratory tract infection or lower respiratory tract.
No, it's not infection नहीं. वो infection से नहीं होता है grunting.
Pathology.
इससे होता है grunting.
Any pathology of lung parenchyma.
Lung parenchyma or lower respiratory tract pathology.
It is a sign or it is a protective mechanisms or both?
Yes.
Which are the common causes of stridor, Parth?
What is?
Common causes of stridor.
Stridor.
Like ma'am mentioned, upper airway obstruction. So can you elaborate some more causes of stridor? Croup. Okay.
Diphtheria, retropharyngeal abscess, severe tonsillitis, then acute tracheitis, acute laryngitis.
And as per IMCI, what antibiotics you will use for the management of pneumonia?
Injection ampicillin or oral amoxicillin plus gentamicin injection intramuscular.
So in IMNCI, how many drugs we are using? Just grossly, which antibiotic we are using in a IMNCI?
In
And in which
IMCI,
situation?
ampicillin,
Yes.
injection ampicillin, oral amoxicillin,
No, no.
injection gentamicin.
Just a minute. જોડે મને condition પણ કે ને કે suppose ampicillin you are giving, in which situation will you give? So possible severe
In-
bacterial infection in all cases, in severe pneumonia.
In possible bacterial infection
Okay.
given, then a severe dehydration
Yes, very
in
nice.
less than 2 month less than 2 month old child. Then
Yes.
very severe pneumonia and very severe febrile illness. Injection
Yes.
ampicillin. For oral amoxicillin for local bacterial infection like umbilical discharge, umbilical redness, or skin pustule.
Very
Or
nice.
in case of malaria endemic region, we are given quinine or artesunate for P. falciparum endemic area injection. And for dysentery, we give oral
Which
cefixime
Pardon? Which injection?
injection artesunate for endemic P. falciparum. Or
Okay.
in dysentery, we can give as per IMCI inject oral cefixime for 5 days.
Okay. Nice.
Which are the 4 signs you will look for to assess dehydration?
In case of less than 2 month, 3 signs are there. Skin pinch gives quickly or slowly or very slowly, and shrunken eye, and general condition like alert, lethargy, unconsciousness, restlessness, or irritable. And in more than 2 months, we can use for ask for drink is vigorously taken or normally taken or not poor to drink.
Okay, where will you pinch the skin?
And in
Specifically.
abdomen
Where? Where
below,
abdomen?
below the in right lumbar area.
Right, lumbar area.
Below the,
How
below the liver.
how will you
below the
pinch?
liver.
For which part
With
you will
How you
injection
put
from
the
fingers,
skin in a horizontal or vertical direction?
Yes,
Yes.
yes.
in
Which direction?
vertical direction.
Vertical direction. Okay.
अच्छा, अभी आप बताइए कि एक 10 किलो का बच्चा विथ सम डिहाइड्रेशन, हाउ यू मैनेज दिस केस इन योर ओपीडी?
In some dehydration, we give 75 ml per kg ORS for 4 hours and looking for after 4 hour reassessment.
मदर इलिटरेट है, उसको पता नहीं कि कितना समय लगेगा, तो कैसे बताएंगे कि कितना पानी ओआरएस कितनी देर में पिलाना है, कैसे पिलाना, कैसे काउंसलिंग करेंगे मदर का?
मदर को we first we calculate the total fluid of in for both we give, इसको बोलेंगे कि उसको बोतल में इतना पानी इतना टाइम में पिलाना है पूरा.
नहीं आप
कितना
समझाओ.
पिलाना? 10 किलो का बच्चा है,
कितना पानी?
2 साल का बच्चा है,
750 ml
है.
750 ml for 4 hours हमको देना है उसको बच्चे को. तो हमको 750 ml की बोतल लेके उसमें ORS 1 लीटर में ORS डाल के 750 ml की बोतल आती है जो उसमें दे देंगे और बोलेंगे कि उसको 4 आवर्स में खत्म करना है.
मदर को कैसे पता चलेगा कि 4 आवर्स कब होने वाला है?
टाइमिंग बता देंगे कि ओपीडी टाइम में एक्सपोज 11 o'clock को आया है तो वो बोलेंगे 3 o'clock
कैलकुलेट द पर मिनट per ml per minute per ml ORS.
Should be advised orally or through nasogastric tube in case of some
If-
अच्छा चलो
dehydration?
कोई बात नहीं.
Maybe if baby
एक
is
चम्मच में
taken orally, then
कितना पानी आता है? पानी कितना होता है एक चम्मच में? लगभग कितना अमाउंट आता है चम्मच में?
10 ml.
10 ml नहीं, जो अपन खाने वाला चम्मच होता है, स्पून, टेबल वाला. घर में काम में लेते हैं ना, मदर को बोलेंगे कि इसमें छोटा जो खाने का चम्मच कितने ml का होता है, उसमें लिक्विड कितना अमाउंट आता है?
15 ml.
उसमें 3-4 ml आता है, 3-4 ml, नॉट मोर देन 3 to 4 ml. यदि हम 750 को डिवाइडेड करें बाई 4, तो 1 घंटे का ORS आपको आ जाएगा 185 ml. देन यू
185.
डिवाइडेड बाई 60, इट इज 3 ml पर मिनट. माँ को बोलो कि एक चम्मच धीरे धीरे एक बार में 1 मिनट में पिलाना है. ओके.
Okay, sir.
If the baby vomit 2 and 3 times during oral rehydration therapy, what advice you do for mother?
First we give an stop ORS for 30 minutes and give antiemetics. Then restart
Which
with
antiemetic you use?
ondansetron.
It is recommended.
If baby is
Any-
more two or more
Any
than 2
antiemetic
vomiting episode,
recommended? Are you routinely given to every child?
no sir.
बच्चों को देते क्या ORS? डायरिया, जो बच्चा ORS पी के उल्टी कर रहा था उसको एंटीमेटिक यूज करते हैं अपन रूटीन में?
नहीं, wait for 30 minutes. If repeated
30 मिनट तो बहुत ज्यादा हो जाएगा, लेट हो जाएगा बच्चा. तो उसको थ्रस्टी है ना, ईगर टू ड्रिंक, सम डिहाइड्रेशन का बच्चा, वो कहाँ वेट करेगा? वेट फॉर 10 मिनट्स. वेट फॉर
10 minutes.
10 minutes. Then restart oral dehydration solution.
Restart.
तो 1 मिनट में एक चम्मच पानी पिलाएंगे, इस रेट से देंगे तो वो जो 750 ml है वो 4 घंटे में पूरा हो जाएगा आपका.
खत्म हो जाएगा.
After 4 hours, the baby condition is same. Means baby is irritable, eager to drink.
Repeat 750 ml per kg as per plan B. Repeat
Per
same.
kg, total amount of 750 ml for next. अगले 4 घंटे के लिए दोबारा देना है ना?
हाँ, रिपीट करना है. सेम रिपीट
What
करना
are the
है.
component of ORS solution? और ORS जो पैकेट आता है उसमें क्या क्या होता है?
सोडियम, पोटेशियम क्लोराइड, साइट्रेट एंड ग्लूकोज.
क्लोराइड कितना अमाउंट होता है, कितने ग्राम्स होता है?
क्लोराइड 750 ml मिलीमोल पर लीटर.
ग्राम्स में पाउडर में कंपोनेंट कितना होते हैं, कितनी मात्रा होती है ग्राम्स में? सोडियम क्लोराइड कितना होता है?
2.6 ग्राम.
ओके, बट देन नेक्स्ट
पोटेशियम 1.5 grams, 2.9 grams citrate and 30.5 glucose.
30 point. What is the role of trisodium citrate in the ORS?
Citrate is by in case of metabolic acidosis is a form of bicarbonate. It helps in metabolic acidosis.
In liver, it converted into bicarbonate. It prevents the
Bicarbonate in liver
acidosis.
for metabolic
And
helps
then-
in metabolic acidosis.
And what is the second other action of the trisodium citrate? It is पानी को सोखने से बचाता है. It is ORS को क्या जमने नहीं देता, हाइग्रोस्कोपिक नहीं होने देता है
Precipitate
ना?
नहीं होने देता.
हाँ. पूछिए सर, कंटिन्यू. मैडम पूछिए क्वेश्चन.
मुझे ये पूछना है कि when will you transfer patient in according to IMNCI? Because IMNCI is again for a transfer, you have to know when to transfer patient.
Is if baby is less than 2 months, we if any generalized danger sign is present,
Possible
we-
severe bacterial infection.
less than 2 months possible bacterial infection is there, or severe dehydration, patient with severe dehydration, with severe pneumonia, and severe dehydration, and acute mastocytitis more than 2 months.
Okay.
In acute mastocytitis, severe dehydration, severe pneumonia, then some dehydration with any other severe classification or low birth weight. We should send refer to any severe febrile, very severe febrile illness.
Very nice.
Complicated same, or
Yes.
then
Higher center, just above your center. Okay, so just tell me, how will you assess feeding in any infant according to IMCI? What will you
first ask
feeding?
first ask
Huh?
to the mother for how
Yes.
many frequency of breastfeeding per days in 24 hours. At least minimum 8 times in 24 hours is minimum for breastfeeding. How and look for attachment, position and sucking for
Will you please
infant in
express the
breastfeeding.
sign of good attachment?
Good attachment sign, 4 signs are there.
Hmm.
Widely open mouth, lower lips should be everted. Most of areola, nipple and areola cover. Upper areola more visible than lower areola, and touch to the breast is a sign of good attachment. And then we
Yeah,
look
how you
for
assess the position of baby during feeding?
position. Whole body should be supported by a mother. All head and body should be in one direction. No any twisting at neck or shoulder.
Baby body should be in a
Decrease
straight
abdomen
posture.
and sorry sir.
बच्चे का baby should be in a straight posture. Straight position है
Straight.
ना?
No any twisting are there. As the nose at the level of nipple area, and
Nose at the
abdomen. Nose
baby
at
mouth.
level of
Baby mouth
baby's
toward
nose
the
at the
mother
level
breast.
of nipple.
Level नहीं,
And
baby mouth toward the mother breast.
and mother towards baby towards the mother. Abdominal for both mother and children should be touched.
तो इसको बोल दो, हम लोग बाग बोलते हैं हमारी हिंदी में, सीधा बच्चा सीधा होना चाहिए. बेबी शुड बी इन ए स्ट्रेट पोस्चर. और बेबी मदर के सामने होना चाहिए, सामने, सीधे सामना मींस बेबी माउथ फेस टुवर्ड द मदर ब्रेस्ट. और समीप होना चाहिए. बच्चे का जो पेट है माँ के कांटेक्ट में आना चाहिए.
एब्डोमेन में दोनों का एब्डोमेन टच होना चाहिए, बेबी और
टच होना
मदर.
चाहिए. और पूरा का पूरा बच्चे को सहारा मिलना चाहिए. बेबी और बेबी शुड बी सपोर्टेड बाय मदर्स, है ना?
Whole body should
सीधा
be supported,
सामने
not
सारा
only
समीप.
neck
ऑल
and
बॉडी.
shoulder.
हाँ, तो याद करो, तुम्हारे सीधा सामने सारा समीप.
Yes.
गुजराती में नहीं आता मेरे को, हिंदी में बोल रहा हूँ मैं इसलिए.
नहीं बराबर ही है सर, सीधा समीप.
How you assess the effective? What do you mean by the effective sucking?
Good and deep with pause. It
Good
is
and
good,
slow
good
and
sign
deep,
of
slow
sucking.
and deep, है ना? Slow and deep sucking followed by
pause. Deep.
Pause करेगा थोड़ा. हाँ, ठीक है. How you treat engorgement of breast? मदर को क्या सलाह देंगे, कैसे ट्रीट करेंगे?
ब्रेस्ट एंगोजमेंट में मदर को बोलेंगे कि एक्सप्रेस करे मिल्क को पूरा जितना हो सके उतना. वेरी फ्रीक्वेंट टाइम ब्रेस्ट एंगोजमेंट ट्रीटमेंट का ब्रेस्ट एक्सप्रेस करके रखे पूरा. और ड्रग इज फॉर.
और क्या कर सकते हो, क्या एडवाइज कर सकते हो?
केबर गोलिंग.
केबर गोलिंग. ये समझ में नहीं आ रहा मेरे को, क्या बोल रहे हो?
मुझे भी समझ में नहीं आया, क्या बोला आपने?
Cabergoline drug for infant dies or single dose of cabergoline.
Okay. What is the difference between the mastitis and
Used for
the this
treatment of
abscess and the
prolactinoma. Cabergoline is used for treatment of prolactinoma. Excess prolactin levels. What did you say about cabergoline part?
Is antagonist of prolactin. So breast protection is decrease or stop.
But that is not used for treatment of breast inversion.
It is not routinely recommended for
If
to prevent
infant is
inhibit
die,
the prolactin. प्रोलैक्टिन को आप इनहिबिट कर देंगे तो फिर दूध तो आना बंद हो जाएगा ना मदर को. यू आर प्रिवेंटिंग द ना.
if mother infant or newborn was to die,
तो कैन डोनेट, शी कैन डोनेट. वो दूसरे को डोनेट कर सकती है ना सीएलएमसी में जाके. पर
frequently express करना है मिल्क को, और सेम एज स्प्रेटम हो तो
चलो ठीक
वो
है.
उसका
क्रैक निपल को कैसे ट्रीट करेंगे आप? क्रैक निपल को
लुब्रिकन, उसको लुब्रिकन अप्लाई करना है और हैंड मिल
कौन सा
भी अप्लाई
lubricant?
कर सकते हैं.
Which lubricant you use for treating the वो क्रैक निपल?
हैंड मिल्क.
हैंड मिल्क है ना. ठीक है. ओके.
Sir, we are having the last student also. So on neonatology, within 5 minutes we will finish. So Parth, now tell by three. Okay.
डबल टाइम हो गया मैम.
Yes.
And from our side, our neonatologist, Dr. Sandeep Kilwani, will take the one.
Good afternoon, everyone.
I start. First of all, good afternoon and thank you to all the externals. I think it has been a long afternoon and all of us are yet to have lunch. So thank you for your patience. We'll finish it off very fast. So I'll discuss a little bit about NRP since I'm discussing about newborns. So Maitri, if you're asked to go for resuscitation of a baby in the delivery room and the baby is yet to deliver, but you are expecting a 29-weeker preterm to be delivered. What are the questions you will go and ask to the obstetrician before the child is born?
First, we will ask 4 questions. What is the expected gestational age of the baby? Second question is color of the amniotic fluid. Third is there any high risk, as we are expecting a preterm baby, and hence this is a high risk delivery. And fourth question is we will discuss with obstetrician regarding cord care, कि delay clamping करेंगे कि नहीं. 4 questions
बच्चे
we will
कितने
ask.
उसके बारे में जानकारी नहीं लोगे?
Yes, sir.
मल्टीपल प्रेगनेंसी है या सिंगल बेबी है?
Yes, we will ask about high risk. Is this a high
The
risk?
number of teams, it depend on the.
Sorry, sir.
How many teams required to resuscitate during? कितने बच्चे?
If
You
there
ask
is
either singleton or multiple pregnancy.
If we are expecting twins, then we will require 2 person who is trained in NRP. And
Okay.
So
first we will ask these 4 questions.
Okay, then after you have asked the 4 questions, before the baby is born, what things you will look for in the delivery resuscitation?
First, we will also counsel parents regarding the expected delivery. If it is high risk delivery, then we will sensitize the parents regarding the expected NICU stay, or that will explain to the parents. And third thing, we will do team briefing and equipment check. In team briefing, we will divide roles to each person which is available for the resuscitation. And equipment check, we will first check all the equipment is available at the moment or not. We will check AMBU, is it functional or not, that we will check. We will check, we are expecting extremely preterm delivery. We will check is mask of 0 size is available or not, appropriate size ET tube is available or not.
Okay, so now what are the special precautions you want to take while resuscitating this baby as compared to a term baby? Or what are the special things in NRP flowchart while resuscitating a 29-week baby as compared to a term baby?
First and foremost, most important thing is thermal care in case of preterm delivery. We'll ensure that delivery room temperature is 25 to 27 degrees Celsius. All the windows are closed or not. AC is off, and we will on the warmer 20 minutes.
This delivery room temperature is for all the deliveries, right? It is not that only for preterms you will maintain a temperature of 25 to 28. Even for a term baby also, as per the guidelines, the temperature has to be 26 to 28. So that is not something different. What are the, I'm asking very specific, what are the differences in the NRP flowchart while resuscitating a 29-weeker as compared to a term baby? What are the differences? Okay, so if this baby is born at 29 weeks of gestation, what are the options for delayed cord clamping? I mean, if you they call it placental circulation also. The other name for cord clamping, delayed cord clamping, one of the broad categories is this thing, placental circulation. So what are the various options available to allow for placental circulation? One is delayed cord clamping. Other than that, what are the other options? Have you heard about umbilical cord milking?
Yes, sir. We'll tell obstetrician to.
It is not something for the obstetrician to do. You yourself can do it. Okay, leave it. So what else? What is? So suppose this baby is 29 weeker. Now the child is born and he is not breathing. You have decided that you need to give positive pressure ventilation. Okay, what are the options available? Which are the devices which you can use to deliver positive pressure ventilation in delivery room?
First, we'll give with AMBU, that is manual resuscitator. Then second, we can.
With what? Are you there, Maitri?
Sir, I think there is some network problem on the student side. So we have taken the Viva and case presentation of all three. So we can stop at this place. So if you permit, then.
Okay. You stop.
Okay. Thank you so much, sir. And thank you, Dr. Unnati.
Thank you.
And thank you, Dr.
Thank you, Rekha. Now it's the time to leave.